Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. We're going to have an exciting and for me, very interesting webinar with Dr. Cecelia Koetting, who's an assistant professor at the University of Colorado School of Medicine in the Department of Ophthalmology in Denver. Her primary focus is in anterior segment and ocular surface disease, neurooptometry, and perioperative care. She partakes in clinical research and has served externship director and adjunct faculty for several schools and colleges of optometry. She's a member of Intrepid, a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, an active member of the American Optometric Association, and has served both local and state officers within the AOA, was named Young Optometrist of the Year by the state of Virginia, and she lectures locally, nationally, and internationally at conferences, contributes articles, and serves on several editorial boards. She is very involved in the profession. She's been a friend of OEC for a while. She's been at several of our events. We're certainly always happy to have her. I'm very much looking forward to because this is now a big part of my practice. So I'm sure I'm going to learn a lot. So Cecelia, please take it away and thank you for being here.
Wonderful. Thank you so much for having me. And I'm always such a not only great to work with you and Greg, but the doctors that you attract, you guys who are here logged in, are always phenomenal to have conversations with. So please don't hesitate to put questions into the chat box, and they'll read them out to me as we can. But I'm really excited to talk about this. And the question that Greg asked, as far as where do we feel about ocular surface disease and dry eye treatments? Yeah, it is a little overwhelming, and especially as we keep getting new ones added in, and where do we go with this and how do we do it? And at the beginning, we're going to kind of just talk a little bit about how we're diagnosing and the way that I look at my patients in order to kind of start figuring out where to go with these treatments and what treatments are appropriate for these patients. So for the purpose of the lecture, all financial disclosures, everything's been mitigated. We're good to rock and roll. The DUES 2 definition of dry eye, right? We remember is multifactorial disease of ocular surface characterized by loss of homeostasis, tear film instability, hyperosmolarity, inflammation, damage, and neurosensory abnormalities being a part of the etiological cause. Guess what? We got a DUES 3 now. Here it is. So, published just within the last week and a half, right? The only change that they said was used to say they have to have symptoms, right? Symptoms was a part of the diagnosis. Now that they say that it's symptomatic disease, right? And we know that I like that kind of tweak to this because when we talk to our patients, there's a lot of them that actually don't have any symptoms, right? Or they may not realize they have symptoms, or if we phrase the same question 12 different ways, we get 12 different answers, and we might actually find that they have symptoms, but I don't have that time, and neither do you. So I like this little tweak just to remind us that yes, many of them are probably symptomatic, but it's not necessarily saying that they have to have symptoms in the way that I read this to be able to be characterized as a patient who has dry eye. So polling question number 1. Greg, are you reading it or do I get to read it?
No, you get to read it. I just get to launch it.
So how many of you in the audience treat dry eye disease or ocular surface disease? Yes, no, and that's a trick question. And I'll explain why that's a potential answer.
When you go back to your definition there, I think probably what I've learned kind of in my functional side of this whole dry eye is that loss of homeostasis. When you
Yes.
get that, hyperosmotic, you lost your homeostasis, you put the stress on the epithelium, the stress on the epithelium, the conjunctiva and cornea. So I'm glad whenever the definition came out, they didn't strike that homeostasis part.
I was too, and I was kind of curious of how much they would change from it, and having some conversations with some of the people I'm sure you have too who are part of DUES. I wasn't getting the feeling that that was going to go away, and I'm glad it didn't. Okay.
The polling question is rolling in. There's probably no questions at this point since we just started, but your polling question is going well here. So let's see here. Think the trend is in. I'll display it. We have 80% saying yes, We have 2% saying no, but we got 20% going with trick question. So
I like it. And you're right, because guess what? Who has dry eye? Everyone. So y'all treat it. Even if you don't think you're treating it, you're also seeing these patients and you're treating it. Okay. Even if you're just going the basics of artificial tears, talking to them about lid hygiene, things like that. And this is all blinking exercises, screen time. We all have these conversations all day long with our patients. And I like to think about dry eye as everybody having it, because if you think about it, we see these patients usually at one point in time during maybe once a year. Just because that person isn't showing dry eye right that moment doesn't mean that they're not going to have dry eye or haven't had issues with dry eye maybe during different times of year. And so thinking about it that direction and reminding our patients, if they start to have problems, come in when they're having it so that we can look and see what's going on and kind of address it. And the numbers really kind of echo this. We've seen these numbers multiple times. If you've ever seen me lecture, I throw the same numbers up. We need new ones. Someone needs to get us some more updated numbers, because these are pulled from 2017, and I know it's up from there. But approximately 16 million patients have been diagnosed with dry eye disease. That's diagnosed, right? How do we diagnose? Put the ICD-10 code in the chart, right? And that's kind of where they pull these numbers from, and how they understand how many people have dry eye is because they're looking at these databases that look at essentially who's been diagnosed with the ICD-10 codes. Estimated 33 million people actually have dry eye symptoms, which we've got a disconnect there between diagnosed and suffering. And then if you actually go even further, I don't have the statistic in here, but only approximately 7 million people are being prescribed medication, 7 million or less, right? So that's, all of us can show hands of who thinks an artificial tear or over-the-counter medication are really going to take care of these patients' problems. We know it's a Band-Aid. It gives them some symptom relief, but it's not going to fix a lot of the issues. So we need to start thinking about what we should be doing and talking to our patients about. This is just another market growth looking at, this is 2022, showing that yes, those who are in North America, we're going to continue to see an increase in trend of those who will be diagnosed or who have dry eye disease. Not surprising to any one of us here, right? Anybody who's in clinic, they're like, yep, that sounds about right. But when we talk about dry eye, and this is where I said, hey, we're going to start here by looking at like the diagnosis and what we think about dry eye and what is it and the causes. So many different causes, right? It can be demographic, it can be environmental, it can be systemic, it can be things that we're actually doing ocular wise, whether it be other drops that we use, contact lenses, Demodex. All of these things can actually affect the patients. We have to kind of figure out what's going on. And going back to what you mentioned, Greg, right? We talk about homeostasis and this cycle. You hear us talk about the dry eye cycle all the time, right? Evaporation, inflammation. Doesn't really matter where you enter into this. One is going to beget the other and then create kind of essentially this larger tumble down a hill, right? And it just gets bigger and it gets worse. So we break this down into two different types of dry eye. And I will tell you honestly, clinically in my brain, I do not personally break these down. And I understand that all of our brains work a little bit different. So I like to make sure I present things. But we talk about aqueous deficient and evaporative dry eye. I don't necessarily go in and say, oh, you've got aqueous deficient, you've got evaporative dry eye. I look at what the issue is. You've got MGD, which yes, is looking at more of an evaporative, right? Or you've got a low tear volume. So maybe we've got some aqueous deficient. So call it how you want, whatever works for you. But we know at the end of the day, it's very rare that someone has one and not the other. It's more common that we have multiple problems, and therefore we have to approach these patients multifaceted. We need to go and approach them. Unfortunately, not just one thing is usually going to take care of it. We need to kind of think about what as a general plan will work for these patients. So not just dry eye disease, meibomian gland dysfunction. And this, similarly, when we look at the numbers, about 30 to 40 million people are actually diagnosed annually, and there's estimated about 100 million who are affected. So we've again got this kind of disconnect between the diagnosis and those who we know probably have meibomian gland issue. And then, of course, Demodex, and we'll talk a little bit about Demodex and some of the treatments here, but this is almost its own thing. And it is its own thing. We know it is, right? It's its own issue. It may be in relation or causing meibomian gland dysfunction, but when we've got Demodex overgrowth, this can lead to a whole host of different problems, and we aren't going to treat somebody who has MGD the same as we are going to treat somebody who has Demodex. We have to get to the root of the problem. And this is just, again, kind of looking at the prevalence. We think about a couple, preconceived notions we may have, right? Is how many people have it? Well, 100% of people over 70 years of age were found in a study to have it. 84% prevalence in patients who were overall 54.9 years of age average that were in this study. So I would say we know this, right? Everybody technically has Demodex, but not everybody has an overgrowth. The overgrowth is the problem. It's part of our natural flora and fauna. I expected to see it, but I don't want it to be causing issues. Another preconceived notion that some people have is that, oh, well, and maybe it's the patients and not the doctors, but it means I'm not clean. I'm not hygienic. I'm in a, I am somebody who is not valuing cleanliness, or maybe this is an issue of those who are in a lower socioeconomic status. Well, there's other studies that have looked at hygiene and socioeconomic status, and it does not actually have anything to do with it. Okay, so let's get into it. How do we determine the underlying causes? Who has one of these? All of us, right? I love fancy tests. I love fancy equipment. Believe me, it makes my life easier, and it's just kind of fun to use to have these things. But at the end of the day, I get more data and more information about my patients and what I need to do for treatment from a slit lamp exam. One of the things you got to do with it, corneal staining. I've had a couple people say, I don't stain and I never see dry eye. And I said, well, that's why you don't see dry eye, is because you're not staining. You do need to stain. As much as we'd love to say, I can look at an eye without stain and tell that it's dry, you're right, you can. But what about all those people who are not to that severe level? What about everybody else that you're not able to appreciate, right? So sodium fluorescein is super important. And then when you're looking at the staining, it's really important to look at the pattern, the location, and the severity. Tear breakup time is another really great measure, a great metric to look at. There's non-invasive tear breakup time that they talk about in DEWS being the ideal, but that's not clinically how most of us work. Me in some studies, yes, but for the most part, no. I'm just looking at our good old regular invasive tear breakup time so that I can see what is the evaporation rate, right? If you feel like you're having trouble being able to see it, a Ratten filter is super, super helpful for picking up subclinical staining, as well as just in general to enhance the staining that you might see with sodium fluorescein. Rose Bengal, you'll see on that top photo there, that's actually a little bit of Rose Bengal. I had a patient who had some irregular staining on their front surface. Didn't quite make sense as far as the pattern, so I threw a little bit of Rose Bengal on there to rule out HSV. So if you see some irregularities or staining pattern with sodium fluorescein that doesn't necessarily make sense, double check it. Throw some Rose Bengal on and see and make sure it's not possibly a early herpetic dendrite. Okay, so when I talk about your pattern, your staining, and the descriptions, this is what I want you to think about. 3 plus SBK is 3 plus SBK is 3 plus SBK, right? Those are all the same? Are they? Right? So we look at the one on the far left. We've got inferior coalesced 3 plus SBK. This patient may be sleeping with their eyes open. Maybe they have a CPAP mask. The patient on the far right, that patient has diffuse 3 plus SBK. This looks more like maybe a metamucosa. Maybe they're constantly using some kind of glaucoma medication that's got a preservative that they're actually allergic to. Patient in the center, this has 3 plus SBK, superior nasal temporal, and it's kind of in this kind of little bit of a whirl-like pattern, and we actually have stippling. So stippling is when you look at the staining, you can see these. Good thing is we're on a computer and you can actually really see this. So you can see that it's almost got these little bit more like rice-like or elongated. They're more linear. And when you see that kind of a staining pattern and you see it kind of going in a little bit of a whirl direction or in one direction, that means that this patient has limbal stem cell issues, and that's more concerning and more of an urgent type. We need to get calmed down. So these are 3 different treatment patterns that I'm going to do because they're going to have 3 different underlying issues.
You got to pause right there
Yeah.
because I had this discussion with my student today, and also your pointable work. A lot of people forget. So if you want to use your pointer to point
Oh,
things,
yay. Yes.
it will show up on the. Everyone forgets on the webinar that it will work. But I just had this discussion with my student today, and this fits perfectly. And I want to do a lecture. Maybe we'll do a lecture together. But I want to call it like when you watch those CSI commercials or Criminal Minds, and they bring in the
Blood spatter guy.
splatter guy, right? That's what we do. It's
Yeah.
like doing blood splatter, and that's what you just did right there. Those all look like blood splatters, but if you look at them closely, that's a left-handed person that did that one, or that
Yeah.
person was sitting or standing, or that was hit from the left to the right, and so on and so forth. See, we have to be blood splatter experts, but we're just
Yeah.
staining experts. So
Yeah, you are.
I love it.
And that's, I love it. Yes, it's a great analogy. I like it. Okay, so, and then also thinking about lid and conjunctival staining, right? So remember lissamine green, do I use it on every single patient? I would love to sit up here and say, yes, I do, but no, I don't have time. But what I do have time is every time somebody comes in as a first patient or I'm seeing changes and no staining on the cornea. The easy way to do it, honestly, I put my lissamine and my fluorescein strips together and I put them on at the same time. I look at the staining at different points because they stain a little bit differently, but you can put them on at the same time and still be able to see what's going on. You just usually have to come back for the lissamine after you've kind of evaluated the cornea. But remember, lissamine is staining dead and degenerate cells, more specifically on the conjunctiva and the lid margin. It's really good for looking for any kind of lid wiper epitheliopathy. And when we talk about lid wiper epitheliopathy, what the concern here is that there's potentially inadequate lubrication, and this leads to like friction, right, between the lid and the conjunctiva, and friction causes inflammation. It can also cause conjunctiva chelosis or some swelling of the conjunctiva that can lead to tearing, all sorts of different things. So don't forget to look there, especially if you're not seeing something somewhere else on the cornea that answers what the patient's complaint is. Don't forget to look there. Good mantra, going back to the lids, look, lift, push, and pull. There's a lot, again, it's kind of another blood spatter thing, but looking at the eyelids, things that we forget about. Ectropion is a big one, or microectropions, right? When somebody's complaining about tearing, or maybe they're not, they're waking up with their eyelids kind of sticky, or they're not getting a full closure. I look at the lids, right? What's going on with the lids? Is there some information there? Also, don't forget, we've got a beautiful picture down here. I know I've got my pointer. We've got a picture down here of somebody who has an entropion, right? So it's rolling in, but this wasn't going on the whole time. I'm sitting here having a conversation with the patient, and I watch it just roll on in, and I go, oh, I know what the problem is. Gotcha. We're good, right? So don't forget to just look at the patient's blink rate while you're talking, looking at the lid positioning while you're talking, watching how often they're blinking, and when they do blink, are they getting a full closure or are they only doing partial blinks? I know technically our blinking and lid closure can be monitored. I've got a picture of it next on our mybographer, but I think that's a false situation. So I take it with a grain of salt, and I watch it more when I'm having conversations with patients. Make sure they look down. Check for floppy eyelid syndrome. Patients may not have been diagnosed with sleep apnea or be using a CPAP mask, but it doesn't mean that they don't have sleep apnea, and that may not also be causing some problems. Another thing to think about is look at this patient here. We've got a nice symblepharon that's going on. So this shortening of the fornix is going to lead to problems. Do you imagine that looking up is really comfortable for either one of these 2 patients who have those adhesions? Nah, it's not really comfortable at all. But let's talk about this far one over here where we've got, this is one of my pemphigoid patients. So this patient was coming back in for a follow-up. I had sent her out to be, we kind of got in her stable. She was doing good. I sent her out to be fit for a scleral lens because I love scleral lenses. I just don't do them. So I referred her to a friend. Friend sends her back and says, "We're having trouble getting in, and we can't figure out why. We were able to do it the first time, but now we're not able to get them in after they had them molded, right?" So I have the patient look down, and I'm looking around, and I'm like, "Well, I can tell you why that scleral lens is not getting in your eye. Unfortunately, we have this nice adhesion here. So the adhesion was missed, but it explains the issue. So don't forget to look under the lids." And this is what I was talking about, blinking and lid closure. Yes, technically my biographer does give me information, but I can't say I honestly feel super content with it. I take it with a grain of salt. Cord Blackie. So this is something I added in probably about 2 years ago. No, I've not always done everything. I did not roll out of the womb doing all of these tests and having a clue what I was doing all the time. It is added in and I'm learning stuff all the time too. So 2 years ago, Cord Blackie light lid test or lid light test. You take your transilluminator, and the whole point of what you're trying to do is have the patient close their eyes lightly like they're sleeping. You hold the transilluminator up here into the crevice in the fornice, and you are looking for any light that's kind of creeping out underneath the lid on the upper part of the cheek. And this can tell us whether or not they're getting a good lid seal. Now, caveat with this is that I have plenty of patients who the Cord Blackie comes back 0. There's no light. But I can absolutely see based on the staining that they sleep with their eyelids open, and it may not be all the time, right? But here's my thought. When we're sleeping, do I go to sleep with my mouth open or do I just wake up with my mouth open? Right? You relax when you're sleeping. Sometimes you do get openings, right? You move around while you're sleeping. Things can get mispositioned and you can end up with a break in the seal. So this is a great test to have some idea, right? But don't say that this means if they've got a 0 on the Cord Blackie that they're absolutely no way they're sleeping with their eyes open. Just isn't the case. We're not getting away from the lids, guys. Got to flip them. Got to flip the lids. Look underneath, look and see what's going on. Does it match what's going in the inferior palpebral conge, or is it different? What else is going on up there? There's plenty of times where I flip lids and I see, cobblestone like this lovely patient here, but the inferior lid was looking beautiful. And I did already mention conjunctiva chelasis, albeit brief. I think this is another thing that is underdiagnosed and underappreciated for how much trouble it can actually give. This is loose redundant tissue. Remember that conjunctiva just starts to get these kind of, I love to explain it like wrinkles in the eye. Patients get it. You get wrinkles everywhere. But a couple things that it can cause, right? It can cause tearing because when the patients blink, we blink from the outside in. It pushes all that extra redundant tissue into the corners and it blocks blocks the punctum so the tears can't drain properly. So tearing can be one thing. Another, if you've got that little wrinkle that you can see right here in this picture, do you think that every time you blink that it's not going to get rubbed on and maybe that's feeling a little irritated? That can cause worsening of irritation, especially when blinking. Another thing is pain worsened in down gaze, and that's so these things can cause a lot of the symptoms that our patients have, but we don't always think about looking at the conjunctiva for conjunctiva chelasis. And meibomian glands. Yes, we need to look at the meibomian glands. They're really important. The oil that's coming out, remember, helps decrease evaporation. It also helps to provide nutrients to our avascular cornea. Our cornea gets all of its nutrients through our tears. And if we are missing some of the components, that's another thing that leads to a breakdown of the homeostasis, right? Okay, so polling question number 2. What do you use to evaluate meibomian gland function in meibomian quality or meibum quality? Cotton tip applicator, my finger, gland expressor, and I don't express the meibum or evaluate. This is a no judgment zone. I'm just asking. Gives me idea for how we talk about things.
And the polling question's open, answers are
Mhm.
rolling in. I want to make a comment on your little micro and ectropion in a sense. You had a great picture there. I don't expect you to go back, but remember, I want to remind the audience that the outside of our eyelid is keratinized and the inside of our eyelid is non-keratinized. And she had a great picture there of that eye being slightly rotated out and that non-keratinized skin kind of converting over. You'll see that
Yeah.
in a person that, sometimes I'll get these ectropions that don't come in for a year and you just see it's all red and starting to, convert over to keratinized skin. And you imagine how
Yeah.
painful that is. So, that's why those are pretty tricky because you got that keratinized, non-keratinized going to keratinized. So.
Yeah. And that can happen. I've had patients who've had severe allergies. It's been hard to get under control. And because of all the swelling and everything going on, it starts to pull them down. So it gets exposed and you start getting that keratinization of that tissue. It's really not very fun.
All right. So, Joe, any questions before I reveal the results?
There are none.
Okay.
Okay, perfect. So
What's the winner?
you've got 55% going cotton tip applicator. You got 30% going my finger right down the line. So gland expressor is 10%. And I don't express the myobum to evaluate, which is 6%. So 55, 29, 10, and 6.
Okay. So overall, everybody's doing exactly what you should. It's kind of what works for you in clinic, right? It doesn't matter what you're using, but you do need to express the gland. So, two things to think about this, right? So when in a quick way to do this is when I'm doing a slit lamp exam and I'm going through and I'm looking at the lids after I've kind of graded the cornea and the tear breakup time and the tear and the fluorescein staining. I'm then going through and looking at the lids and I'm pushing on them and pulling the lid down. As I push, I'm looking at how easy is it coming out, right? Because it should come out when we blink. If I'm having to push harder than we blink, I know that that oil is probably not coming out on its own very well, but also I'm looking at the quality. Remember that the oil should look like olive oil, right? You don't need to use, you can use these grades, have at. I'm not a grade person, especially for this. I like to put descriptors. I put turbid, right? It's kind of cloudy, right? It looks maybe a little bit more milky versus something that's cloudy with debris where I'm getting a little bit thickened or something that's toothpaste like. But we know that it should look like olive oil. And if it's coming out anything other than olive oil and it's coming out easy when we gently push, we got some meibomian gland dysfunction that's going on and we need to deal with it on the front end. I think about this like brushing the teeth and flossing. The earlier we deal with it by doing some at-home therapies, we decrease the risk that these patients are going to eventually have more gland damage, atrophy, and then we're up a creek without a paddle because once they're gone, I can't fix them. And obviously, other things play into this, but it is important to make sure that we're grading expressibility and the quality. Um, Also looking at the eyelids for our lovely Demodex blepharitis or blepharitis, looking for signs of saponification. That just means these little soapy bubbles that we see on this lash line right here, right? Collarettes, I think we're all getting really good at seeing collarettes, biofilm, telangiectasia. Those are those lovely little red blood vessels that are starting to move up into that lash line where they're not supposed to be. Meibography, okay. If I was on an island and I was still seeing patients and I somehow had electricity and I could only have two things, one would be a slit lamp, the second would probably be a meibographer. I do love my meibography just because we look at both the structure and the function. Function is what we were just talking about at the slit lamp. Meibography is really nice to be able to look at the structure and tell me how aggressive do I possibly need to be with these patients based on how much atrophy I'm seeing. If I see somebody who has perfect oil coming out, but they're super short glands, maybe I need to be doing an IPL and a thermoexpression to kind of make sure I'm maintaining what glands they have. I have someone who has toothpaste that's coming out, but they've got beautiful gland structure. It does happen. And I still need to be aggressive with those patients, but I may have a little bit more time to go stepwise approach and have a different conversation with them. This is a study that I did looking at the amount of people who actually had just kind of the correlation between clinical signs that you're finding in the slit lamp versus mybography. And essentially what we found was that 95.1% of patients had some level of gland atrophy. And I'm not kidding. I looked at 400 different mybographers pictures to do this. So it took a while. 4.9% showed no atrophy on the mybography. And then when we looked at it on slit lamp versus mybography, we found that there was more atrophy on mybography versus the same patients who had normal functioning glands. So we saw that there was just not as much of a correlation as we originally would have thought. So another thing to look at is when you are seeing biofilm, or if you aren't seeing film, somebody says, hey, I've been cleaning, I've been really good, but you still see this volcano sign that's right here. This is an indication, that kind of pouching around the base of a hair follicle, that somebody has inflammation, even if they don't have flakes of bacteria that you can appreciate, maybe because, again, like I said, they cleaned. But that's something to be looking at. Another one is this is the red line that often correlates with meibomian gland atrophy. We've all seen these. Yes, we see them more often in our patients who are on things like prostaglandins, but it absolutely is something that's an indication of increased inflammation within those meibomian glands and has been ongoing for some time. Yep. Have your patients look down. Yes, those are false eyelashes. Yes, that's absolutely disgusting. And I hope nobody's trying to eat dinner while we're doing this. So Demodex, do not forget to have your patients look down. However, maybe take an extra step. Have any of you been doing the alpenglow check? This is something that was kind of coined and figured out and verified by Laura Perriman, who's this super awesome ophthalmologist. And what she found was that if you, as you're going from one eye to the other, you take a second and you just look right at the bridge of the nose. If you look for collarettes on the bridge of the nose, that's positive for Demodex as well. Now, what do you do with that? Well, you're going to treat the eyes for the Demodex, but maybe if you're seeing that there, we need to be treating the face or referring it over to dermatology to also treat the face, because if I clean the eyes, but I don't get the face, what happens? Migrate right back in. So we need to be looking at something like that. Lastly, I'm just going to mention another great test that is underutilized, which is not Cochet-Bonnet specifically, but corneal sensitivity. There are way more patients who have neurotrophic keratitis than we know out there. And why? Because we aren't checking corneal sensitivity on a routine basis. Do we have time, and does it work in our clinic flow to do every patient? No, but some things that you should think about when you're thinking about neurotrophic keratitis. A patient that you're throwing everything on and it's not getting better, right? Check the corneal sensitivity. Somebody who should be feeling what you're seeing, they light up like a Christmas tree and there's like, I'm fine. And you're like, yeah, I don't know how you're fine. Check the corneal sensitivity. The other one is if you see corneal staining right in the center and nowhere else, that is also sometimes an indicator. Obviously, we have the other things where it's like you've got a corneal ulcer, they don't feel it, or you've got an open wound. Those are absolutely things where you need to be checking corneal sensitivity because high risk for NK. How you do it? You can use a cotton tip applicator, dental floss. You can use the Brill non-contact esthesiometer or Cochet-Bonnet. It doesn't honestly matter as long as you're doing it. And this is the Cochet-Bonnet. Okay, so guys, let's start talking about all of this and where is it going, right? We've got a number of things that are in our armamentarium. We have ways to help restore that homeostasis when target our underlying issues that now we've just taken the time to think about how we're going to figure out who's got a problem where and what are we going to use, right? Where are we going to use them? We've got our anti-inflammatories, we've got our adjuncts, we've got our face treatments and neurostimulators, but we're here to talk about some of the new things and maybe where are they going to fit. So one thing that we've already kind of we just talked a little bit about Demodex. We're going to jump in there. So I want to start this with a polling question. How do you currently treat Demodex blepharitis? Blepharoexfoliation in office, at-home lid hygiene with tea tree oil, manuka honey, or okra-based cleaner, lotilaner or ophthalmic solution, IPL, or a combination of the above?
And while Greg is opening up that poll, the question came in,
Yes.
is saponification always an indication of Demodex? Or can it be
So
just typical meibomian gland dysfunction?
that is a good question. There's a lot of there's some questions around this. Okay,
Mhm.
so we know that Demodex has two guys, right? We got brevis and follicularum. Follicularum lives in follicles. Brevis lives in more sebaceous glands. So here's the thought: is that while Demodex follicularum is causing the collarettes, we think that maybe the brevis may be causing a change in the composition of the meibum and leading it to be this more kind of soapy, bubbly stuff when it comes out because of some of the Oleranus, the bacteria that it leaves in there. But nobody has really been able to, as of right now, ask me in a year, nobody's really been able to say, hey, yes, we can definitively say that that's what's going on. So could it also still come in other situations just from irregular meibum? Possibly. But personally, I'm using it as an indicator that it may be more of a brevis buildup, and then I'm treating with all these things that we're talking about here.
And correct me, this is me, correct me if
Yeah.
I'm wrong, but doesn't Lotilaner now have an approval for meibomian gland dysfunction?
I'm trying to remember how yes and no, they have data. I don't know that they
Mhm.
have an indication FDA yet. They may be going for it, but they do have data that showed that it helped patients who had Demodex blepharitis in improvement in meibomian gland
Mhm.
function. That's my understanding.
Yeah, so it was a post event. There was a phase 4, I guess,
Yeah.
study that came out. And I know they're allowed to be talking about it because the reps are going around talking about it,
Yeah.
but is it an indication on the package insert? Kind of a play on words that's out there. So can they say it's an indication? It's not on the package insert, just from all the compliance reasons that are out there. But I
Yeah.
think that they're able to go around as a salesperson and talk about it. So I think
Yeah.
that is correct,
Hard
Sharon.
part is if you go to prescribe it for meibomian gland dysfunction, and I do this where I'm like, you may or may not have collarettes, but I'm pretty darn sure your Demodex are causing some of this. When you prescribe it, some of the insurances are coming back and saying, how many collarettes did you see? And you're like, noted, thank you. So just as an FYI.
Here's my twist on the saponification, and then we'll do the polling
Yeah, I want to
question.
hear what
Is
you have to
that
say.
is that if you step back and you just kind of look where it comes from, if you think about it, it's saponification. So I always say if you have lye,
Hmm.
or if you have fat,
Fat and
lye, and
lye.
water, that's a cheap way of making bubbles, right? You have
Yep.
fat, you have lye, you have water. On the eye, you have aqueous, and then you have the fat, which is the meibum. Now,
Hmm.
what's the lye? The lye comes from, and I think I'm just going to take it a step above, just go up a level, is
Yeah.
that it's coming from a bug, whether it's Demodex, whether it's Staph aureus, whether it's Staph epidermis, because Staph epidermis and Staph aureus produce lipase. Lipase breaks down lipid.
Hmm.
So when you break, that's your lye. Your
That's great to
lipase is
lie.
the lipid. Your Demodex messes up that lid microbiome. You have a
Right.
bug problem. Now you have your components to create that saponification. And then that's why I always say, look, when people have that, they usually burn in the morning because when they go to sleep at night, their eye becomes a soap producing machine. And when they wake up in the morning, their eyes burn. So usually I relate to eyes burning in the morning to being bug related. And
Yeah.
that really helps me out. So,
Yeah, not necessarily just Demodex, but a bug.
right.
Yep.
Bug, bacteria, Demodex,
You got it.
something buggish. So,
Yep.
all right, so here's your poll. We got, I'll display it here so the audience can see. We have 9% going with the blepharoexfoliation in the office, at-home lid hygiene, and your list of Manuka honey and okra-based cleaner. 38% went with that. We have 17% going with your Xdemvy, 2% going IPL, and a combination of the above was 34, 37. So you have your winners being tied at combination of the above and at-home lid hygiene, TTO, Manuka honey, and okra-based cleaner.
Perfect. Well, I will say I'm definitely a proponent of the all the above, right? Whatever I can, a combination. IPL may not be obtainable for all of our patients. It's great in a lot of them, especially with rosacea. But we know that Lotilaner, so Demodex is an issue, right? This is not surprising at this point anymore. So this is a study, the Titan study, looking at essentially 1,000 patients, found that of these patients, the 58% had collarettes and 58% also had a dry eye diagnosis. And so they kind of broke it down and looking at 50, how many of these patients actually had mites? 55% of them, 62% had some dry eye overlap as far as the symptoms, not necessarily a diagnosis, and then a 68% blepharitis. So it's prevalent, it's there. We're all looking for it. We've unfortunately now said, yes, I understand, I see it too. Thank you for bringing this to my attention. But what do we do about it? And so I take the multifaceted approach. So just like we think about plaque, if I go to the dentist and they remove the plaque, but I don't go home and brush my teeth, is the plaque going to come back? Absolutely. Now, if I go home and brush my teeth, is the plaque going to come back? Yeah, still going to probably come back a little bit, right? But it's going to be a whole lot less than if I wasn't doing at home. So think about Demodex. If I'm going to put a patient on Lotilaner, and we'll talk about that in a second, I still want them to be doing things at home to minimize how much it's going to regrow and to what extent, so that it can keep a little bit of better homeostasis or a little bit better balance. Because I don't think, the whole point is I don't necessarily know that I want to eradicate them either, like completely gone, or that we actually do ever completely get them to go away. They're part of our natural flora and fauna. So they're there, but we want to keep them so that they're not causing a problem. Couple of different ways to do, because we're here to talk about new things. So I just want to bring some things that maybe you aren't aware of or haven't seen before. These are a number of at-home eyelid exfoliation tools that are available for patients at home. I don't necessarily promote these to my patients. I'm a little bit more concerned because I see my patients get a little over aggressive about things. Some of them have them or will find them on their own. I will have to say my favorite thus far currently that just came out has been the Blink Joy, this little guy over here in the corner. Just because the bristles are very, very soft as far as their silicone, and they're not really rough, and it doesn't have a crazy amount of vibration to it. That's the one I've personally been using, but I still take cautious and I read the room on what patient I'm going to even say that this might be a good idea. Now let's talk about what are we going to use as far as the types of solution for cleaning? Because even if even if they do use an exfoliation for at home, that doesn't necessarily mean it's more beneficial or that it's better at controlling the Demodex. It really comes down to what kind of solution they're using. We know that alcohol doesn't kill Demodex. We know that betadine doesn't kill Demodex. We know that all sorts of things, hypochlorous acid, unfortunately, doesn't kill Demodex. There's just these things that really don't control it, and there's a very few things that do control it on a better basis, right? Tea tree oil is one of them. That's the one we are the most familiar with, right? So this has been shown, this is a number of studies that we know that it does help to keep the Demodex under control a little bit better than using other things. With that, we know it's not 100% effective. There's a number of studies looking at tea tree oil wipes themselves, finding that they aren't necessarily as effective. Greg and Joe, I am going to ask you, what has been your experience with tea tree oil?
Good, Greg.
Well, I like it because it's naturopathic, and that's where I've been kind of studying the last few years. The drawback when I compare it to Xdemvy back to tea tree oil, the efficacy is not there, right?
Right.
And so I don't mind the Xdemvy if I can get it and go through all the prior authorizations and so on and so forth, because it goes after the gamma chloride channel, which is only in the Demodex and so on and
Correct.
so
Yep.
forth. So is very efficacious. However, if I can't get it, it's just a longer grind for the patient because it will work. They have to apply it. We got to tell them it's not a cleaner, it's not saponification, it's actually tea
Right.
tree oil that's actually getting into the mite and killing it. So don't rinse it off maybe till like an hour later because that's what's going in and literally killing it. So it
Right.
works. It's just not as efficacious as the Xdemvy. I have it in the office. I use it. I have the Claridex Light. I have the Claridex lid
Original.
wipes. Yeah, the original, the little wipes. And I tell them, look, they want you to throw it away. I tell them to go out and dab it on, put it back in, and get a couple
It's
uses out of
definitely
it.
got plenty of stuff in there. It's a very heavily moistened pad. Yes.
Yep.
Yeah, I agree. It is efficacious, modest at best. It is my plan B if I can't get Lotilaner.
Yeah. Yeah, and that's why I keep going back to it's not an either or, it's an and. Especially if we can, but there are times where no, I can't get the Lotilaner in a patient's hand, or it's going to be $800, and so we have to make sure that we're doing the best that we can.
Mhm.
Now, Manuka honey is another option,
Well,
right?
I just want to make one comment, but it is a good maintenance after the
It is a beautiful maintenance after. Yes.
Xdemvy. Yep.
Yep.
Yeah, and
I have a number that I use that are I use my eyes the daily lid wipe. It's got like 1% tea tree oil in there. And that one works really well and it's very well tolerated. Because we know sometimes with the higher percentages, some people find it super irritating, but it's needed at the beginning and then switching to a lower percentage is what I like to do if I can.
yeah, and the product that we carry in our office, patients have told me it's very soothing, so they don't mind using it.
Good. Manuka honey. So it's got antimicrobial properties, right? So the whole idea behind this is antimicrobial, antibacterial, anti-inflammatory. Specifically, it's because it's got methylglycoxyl in there. And when we talk about Manuka, which is it comes from New Zealand, that has a higher amount of the methylglycoxyl than other honeys. And that's specifically why we hear Manuka being talked about. This is just one study. There are a number of different studies, but this one specifically was looking at using Manuka eye cream versus, on eyelids for 3 months. And what they were looking at was the improvement or looking for tear film parameters, looking at tear breakup time, the stability, lipid layer thickness, lid margin staining, and then Demodex and bacterial load. And they found that they had an improvement in the patient, in the eye. So they did one eye and not the other. They found that the eye that had the Manuka honey cream for 3 months overall was doing better than not using it. So it is a good alternative. The hard part is there's not a lot of places there's not a lot of products. There are some things that are on Amazon. There's some things that are on eBay with the concern for all sorts of things being recalled and infections. I'm not about ready to go prescribe anything like that from a company that I don't know. So I still say be careful. This is one that is more recently available from a company that we do know, Tear Restore. This is their neutral wipe. It has Manuka honey in it. So this is one option. And then coming soon, there will be a lid cleaner that does have Manuka honey and sea salt foam for daily cleaning. So a couple options, but honestly, keep your eyes peeled because there's going to be more. I've had a couple of patients come in who have diabetic ulcers on their feet. I had another patient who had an unhealing wound on her foot, who's a rheumatoid arthritis patient, and they've been getting Manuka honey that is medical grade. So it's actually in a it's in a syringe that is prescribed to them to use on those areas to aid in healing. So I think that we may see more applications of this as more money gets kind of invested into investigating it. We have to. The money has to be there for these things to be really looked at. Another one that I'm a huge fan of is okra extract. Okra is antioxidative, anti-inflammatory, and so this is another thing that has been developed into a formula for cleaning. There's also a gel that can be applied to the eyes. But specifically, we're talking about Demodex, right? And so this is a study, there's a couple others, but this study specifically looked at okra extract versus tea tree oil, right? And so it was a small study, about 27 patients in each group. And so they were either given tea tree oil or the okra, I think it was an okra pad. Yeah, okra eyelid patch. And so what they found was looking at survival time. So the average survival time for using tea tree oil is approximately 100 and I believe 30, depends on what study you look at, go anywhere between 115 and 150 minutes, which again, Greg, goes back to why you just said you got to leave it on there, right? Because it's got to penetrate. Same thing for the okra. With these okra patches, they found that the average survival time in this particular study for the Demodex once exposed to the okra was about 115 minutes, give or take about 11, 12 minutes or so. So we are seeing that this does help to kind of knock them down. They also found the Demodex count after 3 months of the okra eyelid patch was reduced from about 10 per lash down to about 1.3 per lash. OSDI score of these patients improved, so we're getting improvement in both signs and symptoms in relation to Demodex blepharitis. I would say that I absolutely echo what they're finding here that I see in clinic when I have patients who are using this. And this is my go-to most of the time with Demodex, along with the lotilaner. And I've had a lot of patients who, even if we haven't for some reason be able to get the lotilaner, come back and we notice we're doing a lot better even with just cleaning with something that we know really targets the issue. And so finally, lotilaner, we love you. Tarsus, this is the FDA approved, only FDA approved treatment for Demodex blepharitis. The lotilaner is a GABA-gated chloride channel, as Greg was talking about. It actually, it's an antagonist, so it attacks the GABA-gated chloride channels in the Demodex. We as humans do not have those, which is why, patients will ask, okay, is it going to harm me? There's always risks for the issues with the preservative, but the actual active ingredient itself is really working on the Demodex. Now, the important thing to remember is it only works on the adults, meaning those that are hatched. It does not penetrate into the eggs, and that's why patients really need to stay on it for that I tend to tell my patients go 8 weeks or until the bottle's empty. I know it's technically supposed to be twice a day for 6 weeks, but I say just use the whole thing, right? And that we need to get through multiple life cycles. So we're not only getting the adults that are already hatched, but we're also getting those that are going to hatch.
So the clinical pearl that I'll throw out to that is if you bring them back in 2 or 3 weeks and you're like, oh my gosh, look how good they look, you might stop it because they will look good. So I echo exactly what Cecelia is saying. Keep them onto the bottles empty because they'll look good, but you didn't eradicate the eggs. So
Yeah. 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 You don't want them. Yeah. You don't want to stop too early. So clinical studies, yeah, I would echo everything that I'll go over the clinical studies, but in clinic, it's actually worked very, very well. Collarette reduction, finding less than 2 collarettes per eyelid was really their primary endpoint. They hit that at about an average of 50% between the two studies, the two FDA trials that they ran. But I think what means even more is looking for 10 collarettes or less, right? Because I'm not going to sit there. I could miss 2 collarettes, probably not going to miss more than 10 collarettes on an eyelid. I don't have time to sit there and count all of them down. So 81% got to the point where they had 10 or fewer collarettes. So that's pretty darn phenomenal when we sit back and, think back about what we were doing 3, 4, 5, 6 years ago when we were trying to treat Demodex and doing, in-office cleanings and at-home cleanings, and it would get it under control, but we would really see these patients just kind of flare up around times of season changes. Honestly, that's when I would tend to see it and I'd be like, cool, go back on your Clearadex for 2 weeks or for 30 days, and then, you should be good. And then we'll do this again in 4 months. There you go. So it is nice to have this, but I do echo what I've been saying, which is in conjunction. We definitely still need to do the at-home cleaning. So let's gooch on to the next. We're going to move into the anti-inflammatory area. So how many of your patients currently are satisfied with their current treatment for OSD or dry eye disease? Almost none, forget it. Forget my patients. I'm not satisfied.
Polling question is wide open. So, Joe, any questions?
Nope, no questions.
So one of the comments that I'll make just to kind of fill the dead space is when it comes to you're seeing Demodex and you're seeing overgrowth and biofilms, we always talk about the gut microbiome, the gut and brain axis, and so on and so forth. We do have a lid microbiome. And
Mm-hmm.
then we end up getting these recurrent hordeolums, recurrent chalasia. That's kind of maybe like stage 4, why they're becoming recurrent. You have a lid microbiome dysfunction. So you kind of have to take a step back. Is the patient diabetic? Why are they getting this? Is there a bigger overall picture because those eyes are connected to a person, and is it something else going on? That's kind of because like you said earlier, the Demodex are normal. Why are they overgrowing on this patient? Is their
So
immune system down? So
you think just like me, and I love it. This is why we get along. Gut microbiome is one of the huge things I talk to my patients about. Why does rosacea get worse? A lot of times it has to do with something in their diet, and just gut microbiome happiness. And there's a huge amount of studies right now looking at the gut eye axis, right? And so you're absolutely correct that you have to think about something else might be going on.
perfect. So here we go. We're going to display your answers. So 2% saying all. We've got
I
65%
want
going
your paper.
most. Yeah, well, that was one person, so but it's 2%. So 10% going with none. And forget my patience. I'm not satisfied, 22%. So your biggest ones are 66 at most, and D, I'm not satisfied at 21%.
Yeah, and there's a study that I'm bringing up right now that essentially echoes that our patients honestly, they discontinue their therapy. There's about 30% that will stay on their therapy. Some of them just don't come back, so we don't actually know this. I tend to have a pretty good continuation rate, but also I'm seeing the trouble children that have seen 5 people before, and so by the time they get to me, they're just willing to do anything. So we're a little bit we're not satisfied. Our patients aren't necessarily satisfied. Not all of them. Sometimes our patients are just really, really happy about whatever they're on, which is great. But I think we have to keep the others in mind. And some of this too, we're going to talk about the treatments, but we have to be honest. Some of this is we're unhappy because of how we have to try to get the treatments in our patients' hands. It's not that we don't necessarily have a decent armamentarium and toolbox to work with, but sometimes the access to the tools in the toolbox can be very frustrating and very difficult. So I will put that out there and say, yes, I understand this is not always just about the treatments, it is about the access. And that's a whole other lecture. So when we talk about our current FDA formulations of cyclosporin, I like to bring these up together so that we can see them. I think we forget about Sequa a lot, just because I feel like they're this kind of like little underdog that came in at the wrong time, right around COVID, and they just didn't quite launch as much as they could have. And I actually really like Sequa. It works very well. And remember that actually has that 0.09% of the cyclosporin versus our Restasis or our OG, which is the cyclosporin 0.05%. We also have the generics. And then we also have now our cyclosporin 0.1% with perfluorobutylpentane. So that's actually our highest percentage at this point. And before that came out, I used to use Vercasia, which was cyclosporin 0.1% that was for VKH. I used to use that in some of my patients that really needed that higher level. So now it's nice to have something that's actually on label for these patients, because insurance would like to argue with me on that one a lot. So we have 3 options. Why am I bringing this up? One, we're obviously going to talk about the VEVI, the cyclosporin 0.1%, because that's new. But I also want you to look at this and go, okay, just because someone fails on cyclosporin 0.05% does not mean that they're going to fail on everything in that category. So don't throw out the baby with the bathwater. hold on to it, maybe increase the percentage of the active ingredient and see if it works a little bit better for that patient. Now, specifically with the cyclosporin 0.1%, not 1%, sorry, there's a 0 and a point that are missing, with perfluorobutylpentane, this is kind of a twofold idea here. No, it's not MIBO or perfluorohexyloctane plus cyclosporin. It doesn't work that way. The chains are different, right? And so this is actually a great vehicle because it does stay on the ocular surface for up to 8 hours, which means we get a higher percentage of corneal exposure to the active ingredient, which means potentially better penetration. See where I'm going with this, right? So it is helpful in that respect. No, it's not going to have the same effect as the perfluorohexyloctane or our MIBO, but we do get some of the added benefits from that particular vehicle. And this is a study that was looking at the improvement in the patient's corneal staining within 2 weeks. So we can see here that they started at an average of grade 3 corneal staining. The pictures are great because you can actually see all of these little yellow dots or kind of greeny yellow dots are fluorescein, indicate how much staining they had. And we can appreciate that from looking in a clinic, right? We can see that there's a fair amount of staining. And most of these patients actually went from 12 as far as their total corneal fluorescein staining down to a 9. So a significant improvement. That's clinically meaningful for us, right? I love statistics. They're great. They're important. But at the end of the day, for us, clinically meaningful is probably the most important. Now let's talk about some other ones that are potentially coming. Well, we've got something called a reactive aldehyde species, or a RASP. And what a RASP is, it's a pre-cytokine system-based mediator of inflammation. So it's part of that inflammatory cascade, right? And so looking at that, I don't have a floater. That's actually a bug. Sorry, guys. So if we look at the inflammatory cascade, yes, we can appreciate RASP is up here. And RASP is higher than where we're typically activating, which is our cytokines and T cell activation. Remember, that's where our cyclosporins and lifitegrast work. And our corticosteroids actually work a little bit differently. It's not quite on the cytokines and T cell activation. It's actually just calming things down in the swelling, right? So when we look at this, the idea of if we work higher upstream, maybe we decrease all of the issues that are downstream. And so that's where Reproxalap comes in. And this is a RASP inhibitor. And so some of you may have seen this pop up in the news recently, and we'll talk about that. It's an FDA candidate, RASP inhibitor, that's finished its FDA trials, looking at both the signs and symptoms of dry eye and looking for improvement there. Little tidbit of information. Anything that's going for FDA approval, they actually technically have to look for signs and symptoms improvement. So if they say that, it's not actually that special. It's just how you get FDA approval. So they're looking for signs. It makes me laugh. So everything, the studies are showing improvement, but the problem is that the FDA at this point, this is actually considered a new drug. So Reproxalap has never been used anywhere in the body for anything. Cyclosporin had been used for other things in the body, so it wasn't a new drug application. It was an FDA approval. So when you have something that's never been used in the body, in a human body before, it has to go through a new drug application, and then it can get FDA approval for a drug, right? So it has kind of like twofold that it has to do. Well, unfortunately, Aldera, the company who's developed Reproxalap, the data, they aren't feeling is strong enough. They have now been rejected 3 times. Yeah, because it was 2023, 2024, and then just more recently in 2025, I think they came back in March, March or April, and said, unfortunately, no. So they're still saying that they're going to go forward with trying to do what the FDA needs to show that this is a great drug and that this is something that needs to come to light. But I don't know. So we'll see. So I just like to talk about it just so you guys are aware that this is something that is currently being, attempted to get through FDA approval. Now, another one that is kind of interesting is in INV 102. This is still in phase 2, and it's actually looking at helping to address the DNA damage that occurs with dryness and in general ocular surface disease. So anytime our cells are damaged, right, our body says, I need to fix you. But there's also some DNA damage that happens with that. And the rate of damage can exceed our body's natural ability to completely repair. And so this ends up leading to persistent cellular dysfunction, poor healing, and ocular surface issues. So this is actually looking at trying to use a modified naturally occurring compound P53 protein that helps to activate our body's master regulator of our DNA damage response, and trying to increase our body's natural response to fixing these damaged cells, which is kind of cool. So again, still a little bit far out because we're in phase 2, but it could be something really interesting. They're also looking at it possibly for Fuchs as well as for adenovirus infectious keratoconjunctivitis. So let's move into a different direction. This is another exciting one. So neurostimulation, neuromodulation. So when we think about neurostimulation, neuromodulation, we were just talking about things that help control inflammation, right? This is actually helping to increase your body's tear production. So a secregogue is what they're technically called, but it's increasing the secretions of your eye, increasing tears. And I had this conversation with Josh Davidson recently, and we were talking about how there's 3 types of tears. And he's like, I think there's actually 4 types of tears. I said, that's interesting. Explain. He said, well, we've got our basal tears, right? Those are the ones that our body naturally produces when stimulated by the lacrimal functional unit to provide nutrients. It's our base tear. It's our natural tear. We have emotional tears when we cry, and we've got reflex tearing from when there's something getting in the eye, there's damage, right? It's our body's reflex. But what about when we sleep? We obviously aren't stimulating any of those types of tears, but our body is producing something to keep the front surface moist. And I was like, oh, that's an interesting conversation. So I don't know, maybe we'll come out with a 4th tear in a few years. Totally off topic, sorry. But production of basal tears, so important because it has all of these different components. It has over 1,500, I think it's actually over almost 3,000 different components to that tear. And so it is a very complex thing. Artificial tears do not have this. So in theory, if we can get our body to make more of our own tears and this kind of stuff, we're going to be actually providing our front surface with a lot more things that it can use to function properly than if we put all of the synthetic things on there. Love this idea, right? And in some patients, this is what they need. My patient who uses artificial tears 6 to 8 times a day, and it kind of keeps them stable, but they're using this so much and it's really not doing what I would want it. I don't think those synthetic things are really helping. So putting them on something that helps increase the production of tears. So going back to our lacrimal functional unit, we do have to have a slight anatomy review, right? Lacrimal functional unit consists of our lacrimal gland, our meibomian glands, and our goblet cell, right? They're all making part of the tear film. But also remember, part of this is nerve and a neural network, which includes both our cornea and our conjunctiva. How does that lacrimal functional unit get stimulated? The trigeminal nerve. And there's a couple different areas where we can access that. We know that the trigeminal nerve, as far as we're talking with the branch that innervates the cornea, it also has a small branch on that part on V2 that gets down to the nasal, to the inner part of our nasal cavity. Cavity is the right word? Oh, nasal canal, right there, right there. So this nerve, and we've talked about a couple drugs that utilize that, right? And I said V2, I meant V1. So V1 innervates into the nasal area, but also the cornea. And the drug that we are a little bit more familiar with is varenicline. This is our nasal spray. It was approved in 2021. I think it's worth talking about again because, again, I think it's something that gets forgotten, but is actually really beneficial in a lot of our patients, especially those that we are looking to add something that is corneal sparing or that maybe we want to make sure that we're addressing increase in tear secretion. It is preservative free. It's one spray in each nostril twice a day. Studies, very positive. We see an improvement in the Schirmer score in these patients, and I would say overall, my patients who have used it have very much liked it. Now, the question is, those who didn't feel like it improved something, was I just off the mark? Is that not what the problem was? And sometimes that's actually the case, is I wasn't using it in the appropriate patient. I think it's also important to mention, yes, it is going to cause sneezes, not abnormal. Way to kind of avoid this, and things that do help, but they'll still have some sneezes, is make sure that when you tell your patient how to use it, you're teaching them how to use it like a nasal spray to get to the nerve ending that's right there at the beginning of the nostril. It's not up here. You aren't going to shove it up here like a regular nasal spray and then inhale, because that's not where we're trying to get it, right? We're trying to just keep it right here at the beginning of the nostril where that nerve ending is. So they just barely put it in, they spray it, don't inhale. A lot of times telling them to put their tongue to the top of their roof of the mouth, that helps keep them from doing that automatically. And that'll help decrease some of the discomfort and sneezes that come along with using the medication. But let's talk about something new, something I'm really excited about. So there's this whole other part of the pathway on the cornea, right? So we're talking back about the V1 of the trigeminal nerve, and it has these different receptors. We have different receptors on the front surface to do different things. So we have cold thermosensory neurons, we have polymodal nociceptors, and we have mechanonociceptors. So the polymodal nociceptors detect and warn of irritating, harmful stimuli, produce a reflex tear. So this is something got in my eye, or I've got more of an extreme heat or an extreme cold, and it's activating the sensor. Then we've got our cold thermoreceptors that monitor for change in the tear film and regulate actually our basal tear production. Okay, so looking at it this way, we've got our cold thermoreceptor, and the little guy that's on there is called a TRPM8 receptor. And remember, that's looking for small changes in the air temperature. The polymodal nociceptors are looking for more pain, chemicals, thermal, high swings in changes in the temperature. So let's go back to the TRPM8. So how does that work that it's causing basal tear production? And what does that matter? So the TRPM8 receptor notices small changes in temperature by about maybe 3 to 4 degrees, right? Not much. And that happens in between blinks when tears start to evaporate. So think about when you sweat. Your body sweats to allow it to evaporate to cool off, right? So when the tear starts to evaporate off the front surface of the eye, the temperature drops a little bit. It activates this TRPM8. And that tells our body to activate the lacrimal functional unit, which produces our basal tear. Okay, so what are we going to do with that? Well, we now have new FDA-approved medication as of 2 weeks ago. Ocultramon has an actual name of Tripteer, which is interesting. So it has a full official name at this point, but it is a TRPM8 receptor. TRPM8 antagonist. So it actually activates that TRPM8 receptor that we were just talking about that activates the lacrimal functional unit that makes basal tears. The good ones that we want, that provides nutrients to the front surface. So some of the studies that were looking at this, it was really interesting. So the primary endpoint, they were looking at proportion of patients had an increase in unanesthetized Schirmer score at day 14 compared with baseline. And so I will tell you, I understand you're like, well, one, Schirmer score, I don't use that in clinic. Yeah, neither do I. But I'll tell you why it's important here. And why did they use unanesthetized? Aren't we going to get a reflex tear? So the way that they did it, and I've talked with some of the people who were investigators and why they did this. We don't want to anesthetize. What does anesthesia do? Our anesthetic will keep those nerves from functioning. So then we can't actually get any kind of response from the medication. We aren't getting good info. With the unanesthetized, they were put in, and the patients were, so apparently they had to go through a very long learning curve of making sure they put it in gently so that you didn't cause a reflex tear. And then also thinking about the level of improvement. So when we talk about a reflex tear, you're talking about 20 millimeters or more on the Schirmer's score or Schirmer's test. Like you're going to get a lot of reflex tear versus a basal tear, you only get a small improvement. You're going to get more of a moderate to small improvement versus a reflex tear. So there's a number of other things that kind of went into it. I keep pumping them for questions or answers on that because I want to make sure, especially when I'm talking to you guys, that I feel confident that yes, it's improving. But yes, we had improvement in basal tear response as far as measured with the unanesthetized Schirmer score. And then also a big thing is patients aren't going to use things if they don't feel better. And we did find that there was a statistically significant improvement in the patient's symptoms when using the triptyr or the accultramon. Another one that I don't have here, they also looked at conjunctival staining and corneal staining, and they found that both of those improved. So overall, we've got signs and symptoms approval, which you have to have for FDA approval, right? But I'm excited. I haven't used it. I wasn't part of the study, but I'm excited to get this in hand and see where this works for my patients and which patients it's going to work for. So that is something that hopefully we should probably see and be able to start prescribing in the next 6 months would be my guess. Now, this is also not new, but I think it's important to talk about autologous serum. I think it's another thing that's underutilized. PRP as well. Now, PRP is underutilized because it's definitely hard to get a hold of and it's a little bit more expensive. But autologous serum, we have some more platforms that we're able to get this through. Vital Tears, which has been around, and then there's another one that is um, a a product that was developed by Baskin Palmer that doesn't have to be refrigerated. And so there's a couple companies that are out there that are making it a little bit more available, as well as there's lots of clinics that make it. There's also some local places that can make it for you. Now, why?
Ocubio is the name.
You know, I'm sitting here going, I can't think of the
I
name of
know.
it.
I
Thank
was
you.
going to drive you
OcuBio.
crazy.
Thank you. So autologous serum versus PRP, and what's the difference and why are we using either one of them? Well, they have all of these different plasma factors, growth factors, all of these things that our body naturally uses, right? And that we have been talking about trying to replicate on the front surface. And so with autologous serum, we're using the top two portions of our tube here, right? We draw the blood from the patients, it gets spun down, and then we remove the platelet-rich plasma and platelet-poor plasma, and we dilute it with saline. Now, I've had people say, oh, can't you do higher than 50% when you do your autologous serum? I wouldn't personally, because what you're doing is you're increasing the concentration of inflammatory cytokines and things that are actually in there, such as TGF beta, which actually can suppress wound healing. So you actually get to the point where you're making it worse versus better. So anything, typically, I am a 20 to 40%. Why do I not use 50%? Because it doubles the cost when you order it from Vital Tears, and I have not personally found any difference between a 40 and a 50% in those patients who were previously at 50%. So I typically am either a 20 or a 40. Now with PRP, you don't do percentages. Why are you not doing percentages? Well, because it's 100% that platelet-rich plasma. It is not diluted at all. It is 100% that, which is another reason why it's a little bit more expensive, right? But what's the benefit there? You've now taken out the inflammatory cytokines that are in the platelet poor plasma that is not separated out in our autologous serum. So this is something that's used in aesthetics. This is something that's used in a lot of different injections into joints and areas where cartilage is damaged. It's been used in a lot of different disciplines. We in eye care use it. Canada uses PRP a ton. They've almost exclusively gone over to PRP versus ASED, but we don't use it here as often because it's really hard to find someone who's doing it. I know that's for me the big reason I haven't done it. What about you guys? Do either of you have any experience with PRP?
Yeah, we actually do it in our practice.
Yay!
We have a PA and she's involved in the dry eye service, and we just refer to her, and she creates this for the patient. So we do it all in house
I
because
love that.
we use so much of it.
That's awesome. Would you say historically have you used autologous serum in the past?
Yeah, we started with autologous serum, and we have now segued more to PRP.
Do you feel like you have a better overall response with the PRP?
I do.
Okay.
I
Thank you
mean,
for doing what I,
and for all these reasons that you have up here.
yep, perfect. And
The only
think,
comment I'll make about the
yes,
autologous serum is when you go from that 20 to 40%, warn your patient that they're going to take a little bit more blood that's in, because if they're going for 20% and they just take X amount of blood out, they almost have to take twice the amount of blood
yeah,
out, and
yeah,
they get a little shocked at that. So
yeah. Um, And I'm going to talk about autologous serum for neurotrophic keratitis here, but that is by no means the place you have to use it. This is a great place to use it. I have it in my patients who are, mild and moderate dry eye. Sometimes we find that this is actually less expensive of an option for some of my patients than it is for them to get medication that they have a high deductible plan. So it's not your end stage, it's not your severe Sjogren's patients it works well in. It does work well in those patients, but I don't want it to be pigeonholed for only severe patients. There's a lot of other applications for it. But autologous serum for NK, this is absolutely one place I use it. So this is a study looking at patients who were treated with autologous serum versus those who had actually had oh, this is a different study. So this is looking at those treated with autologous serum and an increase in corneal sensitivity in 64.2% of the patients. I will show you one of my patients here. So this is a patient who is a 25-year-old who had post LASIK neurotrophic keratitis, and this is her after 8 months of autologous serum on 40%. What we can see here in the confocal is we can actually see regeneration of nerves. So the little the red arrow is pointing to nerve beating. So we're getting nerves that are coming back from where they were. And then in the top one, you get little short nerve stumps that are nerves that are actually new baby nerves that are regrowing. So we do know that we get nerve regrowth with using autologous serum. In my NK patients or my neurotrophic keratitis patients, most of the time, if I can, I'm getting them on Synedrimin or Oxervate. And then so I get kind of like kickstart them. Usually there's probably an amniotic membrane before they get on that because I'm trying to get it approved. And then afterwards, I tend to do about 8 to 12 months of autologous serum, 40%, to just make sure that we're just keeping them going in the right direction. And I'm controlling all of that ocular surface disease and inflammation I possibly can. So great place to use, great adjunct therapy for after your patients have finished Synedrimin.
let me
Well,
make one quick comment here is that we keep talking functional allopathic being opposites cure. And it's kind of neat because we keep switching back and forth, right? So Claridex, which is tea tree oil, that's kind of naturopathic, autologous blood serum, PRP, natural. Then we have, accoutrement, triptyr, which is now going to be allopathic, stimulating receptors. So it's
Yep.
kind of cool. We keep shifting back and forth. I just want to point out to the audience that there's some naturopathic things and there's some actually, like cyclosporins that are
And
out
they're very
there.
synergistic. They're
Yeah,
very
they are.
synergistic. And I think
Yep.
we're not talking about nutraceuticals, but I know both Greg and I are huge proponents of nutraceuticals, and quality is a big question there. But,
Hmm.
all of these things just they work very well together. And when I started this whole lecture out, I said it's very rare that my patients are going to do one thing and that's going to fix it. We're going to attack this from all directions because that's what's needed.
And that's, that goes back to acute versus chronic, right? When you look at an acute problem, like corneal abrasion, I think we all could probably treat it the same way. That's an
Mhm.
acute problem. These are chronic conditions. Chronic conditions need strategies.
Yeah.
And not all the strategies are the same. So
Yeah. So we're moving into my Boehmian gland dysfunction and evaporative dry eye because again, I don't bring them down into areas, but I want you to kind of think about those two as synergistic, right? They're kind of in the same realm of kind of what they're talking about. So poll question number 5, true or false, punctal plugs cause worsening of ocular surface inflammation?
Polling question is open. Joe, are there any questions?
I'm going to look at right now. Nope, we're good. No questions.
Punctal plugs cause worsening of ocular surface inflammation. True or false? The question is open. Answers are rolling in. I think we got ourselves a pretty good trend going here. I'll
Okay.
just share it real quick. We've got, ooh, it just changed slightly. So we've got 60% saying true, and we got 40% or 39%. It just changed going to false. Now it's
Good.
59
I love
41.
that this is divided. Okay. And I'm going to tell you why, because I was in camp A and now I'm in camp B, but I was in B. Yes. So I originally did plugs all the time. And then for some reason, I don't know, maybe 2, 3 years ago, I got in my brain and I was like, wait, should I be doing that? Am I maybe just plugging up the dam and I'm leaving all this inflammation on there and I'm making it worse? And then somebody recently said, Koetting, someone did a study on that. And I said, okay, well, let's look at this. So this was a study that looked at punctal occlusion in MMP9 markers, right? And so they found that using punctal occlusion significantly decreased global irritation symptoms, improved symptoms, decreased corneal fluorescein staining. And after 3 weeks of punctal occlusion, there was no significant change in the overall cytokine or MMP9 levels observed. So while it did not necessarily decrease the inflammation, and that argument can be made, right? It did not worsen it, which was my big concern. And I was like, well, am I just adding on to the problem here? And I'd been holding off. So I've gone back to doing punctal plugs in the last 6 months on patients, having good response, still being thoughtful on who I'm using them in. And I still am in the camp of using temporary plugs. And the reason for that is because the dissolvable temporary plugs sit below the surface. So again, going back to that conjunctiva chalasis, all those things, with the permanent plugs, two issues I've had with them. One, they don't tend to sit flush. And so patients will blink and we start to get rubbing and we get inflammation, right? Where we are potentially adding inflammation at that point. Two, I've had a number of patients who've come in where they've had their punctal plugs for 20 some odd years. Amazingly, it didn't fall out. And then we've got all of this gunk that's caked on there. And it's really potentially just making kind of a soupy mess problem there. So those are my unloves about permanence. We can talk about it from the other clinical side of this in clinical builders. If you're putting them in every 3, 6 months, that is a revenue thing, right? And we're still appropriately treating patients, and there's other reasons. But so that's a thought to it too. So this was a study looking at safety and efficacy of lacrimal drainage systems. So this is something else that's a new option. They were looking at plug placement resulting in 50% improvement of symptoms, but plug loss was the most common problem with punctal plugs in about 40% of patients. 9% having epiphora, 10% required removal because of irritation. Same things I was just talking about. Cannuliculitis in about 8% of patients, and some other problems. So, enrolls a new option, something called Lacrofill. And this is a pre-filled injector. So those of us who've ever done dilation irrigation, this is exactly this, well, pretty much exactly the same thing, right? Except we are pushing in hyaluronic acid solution. So this is an HA that is a gel. And the gel fills up the lacrimal sac. And so you actually only go through one punctum and it goes through the sac and up and around. So you get a full not blockage, but it's a blockage. So you're getting the occlusion of that system, same thing you would. But there's some thoughts that there may actually be some drug eluting effect from that lacrofill because it dissolves over about 6 months. and it's continuously putting HA into the tear film. And so they think they're trying to prove this with some of their own studies that they may actually getting the HA helping the front surface. And we're not that's not new, right? We have HA in a lot of our artificial tears, and we know that HA is helpful because it actually binds to water and helps retain water on the front surface, and that's why it's in the artificial tears. So it wasn't too far-fetched for me to think that yes, that may actually be the case. So just so you can see a little video of how it is administered. So we're going in. There you go. And then it dissolves. Okay. So what about the yeah, we're still talking about my Bowman glands here. I was thinking where it was going. Okay, so treatments as far as lid margin disease, because this gets into our meibomian glands, right? We were talking about evaporative. This is also in part evaporative as well. We know warm compresses and lid massage difficult to maintain. Still good to talk to your patients about, in my personal opinion, but we know it's not necessarily. I mean, who flosses every day? And if you say you do, good for you. But I'll be honest, I don't. Like 3 times a week. Most of our patients are probably doing warm compresses that much as well. So what can we do in clinic? This is actually not that. This is more about nocturnal lag ophthalmos. These are sleep tight, sleep right. This is an alternative to patients who are not a fan of ointment or struggle with ointments. This is a good alternative for them. I was actually going into here. So thermal expression. And so this was a study that was done by Sight Sciences, and they were looking at, what is the comparison between doing branded Restasis or doing a tear care thermal expression. Now you might be going, why would you compare those two? Well, what is the number one thing that's given to patients who have dry eye? Cyclosporin. It is still the number one, regardless of the etiology. And so this is not only to show, one, that thermal expression is important and it does help, but two, remember that cyclosporin doesn't fix everything, especially meibomian gland dysfunction. It does nothing for it. So what it looked at, it was following the patients. They were either put into arm tear care or Restasis. And then at the endpoint, the primary endpoint is 6 months, patients were then moved from the Restasis, they did a crossover. So they were actually moved into the tear care arm as well, so that they were able to see if they improved by doing a treatment at that point. And so what they found was tear care was superior in outcomes initially to branded Restasis, improving tear breakup time, multiple measures of meibomian gland dysfunction. Both treatments produced significant improvements in patient-reported symptoms, so not surprising. But the compliance with the branded Restasis and Sahara was atypical of the real-world patient. They did notice that the patients were actually doing approximately 5.7 bottles over 6 months. I will tell you, my patients will go through 3 bottles in 6 months sometimes. We know that they're not always compliant. And they did see in those who crossed over, they did see a significant improvement. Even though they had already improved with Restasis, they still saw more improvement when they went to the crossover phase from using Restasis to having a thermo expression done. So in conjunction, it's maybe we need to do more than just one thing. Restasis doesn't fix all. Thermo expression doesn't fix all. Look at the problems. Sometimes they need both. IPL, or intense pulse light therapy. I know not everybody's going to do this. Not every patient needs this. It is a phenomenal option though, and I just like to talk about it. So if people are thinking about it, or they're getting ready to purchase, or are on the fence, one, you need to look at your patient base, and see if it's warranted. There are plenty of people out there who have bought IPLs, thought it was going to be great for their office, but then they weren't quite sure what to do with it or which patients. Have a plan before you buy it, and know that it's not going to be every patient, and see if your patient base can actually withstand it. It is indicated technically for lots of other things than what we use it for, but we are typically looking at it for bacterial load decrease in our patients with ocular and facial rosacea, blepharitis. We're using it to treat dry eye and meibomian gland dysfunction, telangiectasia, and lid margin inflammatory issues, as well as we do get some heat created to help get the impacted meibum more mobile. We do have to be thoughtful. This is not for every patient. Again, not just because they may not have an issue, but also because there are some contraindications. The big ones do have to be do with more with your Fitzpatrick scale, and having to be cautious. There are different protocols for patients who have type 5 and above skin, but that may not be something you feel comfortable doing, and that's okay. Active infections we do want to typically avoid. I say that hordeolums I won't do, but chalazions are okay. We do still want to make sure that that infection is under control. Dysplastic nevi, so if you think somebody has something that looks like it may be not benign on their face, don't treat it. Send them out first and get that looked at. I used to have on here chemotherapy and some other drugs for cancer treatment, but that's actually not a hard and fast. I have lots of patients who are actually undergoing concurrent. We just have to be aware and adjust the settings for them. Some complications: pain, erythema, edema. Edema is going to happen if you were too aggressive and you did not use enough lubricate or the jelly. Don't be stingy. Use tons of ultrasound jelly. Get it all on there. Make sure you're getting every area you're going to go. If your male patients have facial hair or stubble, don't treat that area. That's not going to go well. You're going to hit the stubble or the hair and you're just going to burn it. Okay. If you accidentally get a little one, that's fine, but don't treat those areas. The light's not going to be able to penetrate. Remember, it attaches to reds and browns. And so that's where it's going to stop, is where you've got the melanin. But the idea behind IPL is looking at photothermolysis is one of the mechanisms, right? So we're going towards different wavelengths, right? I'll use a 450 to target more surface for bacteria and Demodex. The shorter wavelength is more surface. And then I'll go to a 510 or a 540, depending on their Fitzpatrick scale. And that penetrates deeper into the skin. That's going towards the chromophores in the red blood cells and to the patient's blood vessels to help to decrease the amount of inflammatory mediators that are getting to that area. The other thing that we end up getting is a little bit of heat to the area around the eye, to the meibomian gland. So not only are we decreasing the inflammatory mediators that are going up that direction, but we're also getting a little bit of heat and disruption to that meibum. I do couple mine anytime somebody has it done. I am doing an expression. I do manual. Why do I do manual? Well, because I'm at a university and we're not allowed to do the out-of-pocket ones anymore because of some issues with reimbursement. So that's my reality. But I would tell you, I still get really good results. I use a disposable heat mask. There's little, like the Bruder one-use ones that you open that are kind of like little hot hands. There's a number of different companies that make them, but I have them sit with heat for about 10-15 minutes after the IPL, and then I do manual expression, and I do get really good results. If you're really interested and you have nothing to do on a Saturday night, I am more than happy to supply you with a number of different studies that go through peer-reviewed literature on IPL and meibomian gland dysfunction and how it's working, as well as that it does work. Now, another one, radio frequency. I am not doing this. I'm just going to be honest. I think it's amazing. I've got other friends who are doing it, looking at this more for collagen and some other things. It does not work the same as the IPL. This is not a photobiomodulation. This is radio frequency. So this is not something I have a lot of information on, but skin laxity, wrinkle reduction, radio frequency kind of helps with that. If you're looking for more information on this, reach out to our friends or look for articles by Selena McGee. look for articles or anything. This is Shane Swats, who practices out of Richmond, or not Richmond, Virginia Beach, Virginia, and he does a ton of it. Do either of you two gentlemen do radio frequency in your clinic?
I do IPL. I looked into radio frequency, and we're still tossing around to see if we can with that business plan that you were talking about. So
Yeah,
Yeah,
yeah, that's true.
we are not. We are not.
Okay. Yeah, I think it is a place. It just depends. Is your office the place?
right.
Absolutely. So, in the interest of time, I want to chat about perfluoro 100% because I did mention this 100% perfluorohexyloctane. This is our MIBO. This is really good for signs and symptoms of dry eye disease associated with meibomian gland dysfunction. The way that I look at this is mimicking the meibum in the tear film. So it doesn't replace, and that's a big thing we have to remember, is it does not replace them. It does not get your meibomian glands to function better, but it does mimic the meibum in the tear film. In such, it does not provide nutrients, but it helps to stabilize that tear film so that it doesn't evaporate as quick. That decreases the evaporation, right, and desiccation exposure of the epithelial cells, leading to damage, the desiccation of those epithelial cells. So it helps decrease some of the stress. Now, I like this in the patients who have poor meibum while I'm working on getting their meibum to get better. And in some patients, this is something that's made a huge difference for them. Again, getting into hands, that can be difficult sometimes, especially for our patients who are Medicare, Medicaid. The longer a medication is out, the easier it will be for us to eventually get it to them. But overall, I've been very happy with how this has worked for my patients. Two things on how to use it. It is a very, very small drop in a bottle that is very small. So be prepared. Your patients are going to say this bottle is tiny. That's never going to last. When they use it, because the drop is small, it's 100% active ingredient. There's no water, right? That's why it's a very small drop. When you go to turn the bottle over, the drop will come out on its own. Your patients do not need to squeeze the bottle. The drop will come out. If they squeeze the bottle, they're going to do what happened to me when I used it the first time and get half the bottle on their face. Then, yes, it really won't last an entire month. The other thing is that in my patients, it is dosed at QID on label. I tend to use it 2 to 4 times a day. And I'll have them go 4 times a day, usually for the first month, just to kind of get used to it. And then I'll say, okay, now we can kind of decrease and you can go 2 to 4 times a day, depending on how much you're needing it. That decreases, how quickly they go through the bottle as well. And I really find that that works very well for the patients. Investigational drug. This is another one that's kind of interesting that I'm really excited that is in the meibomian gland space. This is AZR-MD001. So this is a selenium sulfide ointment. So selenium sulfide, you might be going, I recognize that. Well, it's what's in our Head and Shoulders dandruff shampoo. This is actually pulled from an original study that was done in the 1950s. And they looked at using selenium sulfide, disulfide for helping to open up the meibomian glands and getting the meibomian glands functioning better. But it was kind of shut down in the 50s and they didn't do anything. Somebody pulled it out again in the 2000s and said, why did nobody go anywhere with this? And they started looking at it. And so the thought is, and what it does is 3 different things, right? So the selenium disulfide actually helps to break up keratin that's within there. So we know that we get keratin plugs in the meibomian glands, and that's part of what leads to the oil not being able to come out. So this helps to start to break that up. The other thing that it does is it helps to, it's a keratolytic. It also helps to slow down the rate of keratin production, and it helps to stimulate lipogenesis. So the increase of our meibomian gland function, right? So increasing the meibum that's being produced. So this, I'm really, really excited. They are done with their phase 3 data. They're still processing it. They haven't released it. They are getting ready to submit to the FDA, but they are finding that using this ointment on the eyelids at night, twice a week, which is totally doable, right? Patients are, it's way less fighting twice a week on this, that they're seeing an improvement in the meibomian gland secretion score. So we're seeing more meibum, better quality meibum, and more glands that are actually starting to open. So this is something that I'm really excited about. How much time do we have left?
I think we're about there.
We're about there. Perfect.
We're there.
Well, then we're gonna wrap up and see if anybody has any questions, and I'll let you guys do your closing.
Well, nothing has come in recently, but it could possibly come in right now. But I think we're good.
Okay, perfect.
I'm gonna unshare in a second. I see you have your thank you there. I see you have your email up. So
Yeah,
I'm
if
giving
anybody
people
does
just,
have questions, send them my direction.
and I'm gonna give them a second to grab that. And I'm gonna stop the sharing. I'm gonna go and
Okay.
share mine. And as you can see on your screen, if you look at the survey, there's that little yellow or little red dot that you can click that and start the survey. You don't have to wait 8 minutes to get that post-event survey. So start that survey now. So we are, Joe, any final questions that have rolled in? This is the
None.
question part.
None.
All right. Well, Cecilia, thanks for doing such a great job of I can't get no satisfaction. I think people will get satisfaction after listening to this great talk, new solutions for ocular surface disease asynchronous course.